Welcome everybody, and thank you all for joining us today on our webinar, Ready, Set, and Now Go. The RX Paradigm team and the Powers team would like to thank you in advance for carving out some time to hear what we think is a extremely important message and conversation. So welcome. Today's speakers will be Bill Von Olson, who is a principal at Powers, Tim Nealon, the COO of RxParadigm, Mark Ungusushi, who's an associate at Powers, and my name is Carlo Cioffi, and I'm the Vice President of Sales at RxParadigm. I'll throw it over to Mark and for a little welcome from the Powers folks and to address some of these other next slides.
Yeah, so just really quickly, my name is Mark Ungusushi. I'm an attorney, doctor of pharmacy at Powers Law Firm here in Washington, D.C. I have the pleasure of practicing law with a lot of pharmacy sprinkled throughout with Bill Von Olson, who helped write the 340B statute. I wanted to welcome you all for attending this very timely presentation. I just wanted to make sure everybody understands how important the subject matter is, right? As you all know, the 340B program's drug pricing and purchasing program, it serves as the foundation of the public health infrastructure in this country by providing critical support to safety net providers who serve as the backbone of that public health infrastructure. And as we know, the 340B program has been going through some challenges lately. And this is kind of like a historic moment, in my opinion. What RxParadigm is proposing to provide and explain and demonstrate through this presentation is the importance of a neutral, trilateral clearinghouse to benefit drug makers, covered entities, and payers. This is a critical moment in the history of the program. It's a critical moment, in my opinion, in the history of the public health infrastructure of the country. And so we just hope you tune in and just recognize the importance of this presentation. I'm going to quickly go over the disclosures and I'll just say, turn over to Bill if he has anything to add. Bill and I represent pharmacies. We represent public health safety net providers. I grew up working at Grady Memorial Hospital throughout high school, one of the critical safety net hospitals in the country. So just we want to disclose that we represent safety net providers and pharmacies and third-party administrators. I have minor stocks in some drug companies, a couple $100. FYI, we're lawyers. We represent safety net providers in litigation related to the 340B program. And hopefully after this presentation, such litigation won't be necessary. If we could go on to the next slide. And I'm going to turn it over to Bill. Bill, did you want to add anything?
Well, I just want to amplify the point you're making is that in some areas where interests are adverse to those of the pharmaceutical industry as well as the payer industry, because we represent the interests of covered entities and 340B service providers. But this is one area where we do think all stakeholders have an aligned interest, and so there would not be a conflict. And that's why we're involved in this, because we really think this is an area where everyone's interests are consistent with each other.
And so we'll turn it back over to Carlo to give an overview of the agenda for today's important discussion.
Yeah, thank you, Bill. Thanks, Mark. Before I get into the agenda, a little housekeeping. Microphones are on mute today and cameras are off for sure. So we would ask that during the Q&A, you put any questions in the chat feature. You can put them in at any point if they pop into your head during the webinar, just so that we have them stacked up and ready to go during Q&A. So for the agenda, we've got about 8 major topics to discuss, a little overview of RxParadigm. Some folks might be familiar with the Powers team. They've been around for a long time doing really good work. So we'll go over RxParadigm. We'll talk about Clearinghouse Ready, which was a topic we addressed and brought up in June in our webinar. Key messages for today's webinar, and really look at the double payment problem and what is driving all the change that Mark addressed earlier. Clearinghouse benefits for CEs and manufacturers. We'll touch on the rebate model as well, because that has been brought up recently and was in the news. And then Tim will take it home and talk about how we're bringing the clearinghouse to life, talk about it and as it's now time to go, as we like to say. A little bit about RxParadigm. We are a leader in the technology solutions space for pharmacy and drug supply chain. The sector has been going through a lot of change, as Mark mentioned, and we bring solutions to the marketplace to provide transparency and ensure sustainability, very specifically in the 340B program. We know that the program cannot really sustain the pressure that it's under. The collaborative approach of RxParadigm, as Mark said, brings all stakeholders together in really focusing on what we call and consider equitable outcomes. I think the one thing that we like people to think about when they think about RxParadigm, we like to use the word neutral, but any other word, unbiased, nonpartisan, our approach in the air quotes 340B wars that have been happening over the last number of years is as a neutral party, and we like to shine a spotlight on that. Our founders of the company are Messin Tenganu and Chris Chan, both industry leaders and veterans who were frustrated and with the landscape in 340B and very specifically duplicate discount. Each brought a unique perspective to the challenge of duplicate discount and how to address it. These two innovative leaders built a solution that really relies on collaboration. As Mark suggested and Bill suggested earlier, we're never going to get through these challenges without some level of collaboration amongst all stakeholders. And they address duplicate discount in a way that ensures CEs and manufacturers can have confidence in the results. So we are more than excited to share today a little bit about the platform and the company and the solution. So key messages. So for us, there's really one major message that we would like everyone to currently take away and understand, is that for the first time in a long time, covered entities have a neutral platform, a unique opportunity to share information in a neutral way through a clearinghouse that addresses the major concerns that Tim and I hear a lot when we're around the we've been around the country doing some speaking engagements and on day-to-day calls with prospects, is that people are concerned about data integrity and privacy. And now finally, there is a platform in the market. It's a market-driven solution where covered entities can participate this way without fear of exposing data. We like to say it's an opportunity for people to, as we say, act locally. Start with your system or your health center and really start to be a player and an actor in guiding your own future. I think our biggest fear, one of them that we have, is that if the solution is only federally or mandated through law, that it might take a form that is not beneficial to all players. So we all really feel like we have an opportunity to craft a solution today. And the why that message resonates is because it's been 5 years of disruption between contract pharmacy restrictions, the introduction of a totally different rebate model, which I said we'll address, federal legislation, state legislation, and lots of back and forth between manufacturers and covered entities in the form of lawsuits have really thrown a monkey wrench into the program. And we cannot sustain another 5 years of this level of disruption. So the clearinghouse. So in June, we did a webinar where we talked about and introduced the market-driven clearinghouse. And the solution's name is Tungsten Plus. And again, it is a clearinghouse that is really, think of it as a claim identifier. And the reason we know that this solution is really the starting point on a path forward is because we ultimately addressed the 340B claim modifier issue. And so we believe that this is where the problem really exists. And we'll talk about that in a couple of slides down. But it's proven to be unreliable. And so when unreliable data flows through the value chain, drug manufacturers, states, MCOs do not have the ability to identify claims. And this is why duplicate discount happens. We know that if we can put some mechanisms in place and tools in place, that ultimately all those players will have the ability to identify 340B claims, and duplicate discount will minimize or go away down the line. And if that happens, ultimately we'd love to see the program back to March 2020, where the temperature in the room is down and all the stakeholders can really feel happy with their compliance and the level of their program. This is a 30,000-foot view of the clearinghouse. It just shows how the players interact with the clearinghouse. Tim and I were at a conference recently, and the two questions that we got mostly that day were about the clearinghouse, were about certification of claims, the certification of the technology and the security, and role-based access is really what people were asking us about. So the 2 points we like to stipulate and shine a spotlight on are, one, again, is our security. The system was built with high trust in mind. So kind of, if you think of the foundation of a home and the framing of the home, we framed the system and built the foundation on high trust. Our high trust certification will be completed by the end of this calendar year. So we're excited about that. And the other question we get often is about access to data. Part of where covered entities, I believe, is on less than 40% of the covered entities today participate in ESP. And the feedback from that is because of data access issues and security issues, and what will the data be used for. So Tungsten Plus has a role-based access for all stakeholders, only allowing data that they're supposed to see related to claims being 340B or not 340B. So I think when we look at kind of why are we here, right, it's the double payment issue. As you can see from the chart on the right, the 340B purchases have grown over the years exponentially. The program has grown. So through that logic, double payment has probably been most likely grown exponentially as well. And double payment is when 340B claims are submitted for rebate from any one of those additional payer channels through commercial, Medicaid, or Medicare. It was estimated that in 2023, over $15 billion of WAC were payments, overpayments in 2023. So it's a big number, and it catches everybody's attention.
Yeah, can I jump
Mark?
on that one, Carlo? So,
Yeah, please.
just to be clear, we're referencing $15 billion of duplicate discounts. I want to level set, and Bill, feel free to jump in. But that $15 billion is not, that's Medicare, Medicaid, commercial, right? And so just keep that in mind, right? That's not the manufacturer's fault. That's not the covered entity's fault. As we know, it's only Medicaid fee-for-service that is covered entities responsible for preventing, under which a covered entity is responsible for preventing 340B drug duplicate discounts. But in the realm of Medicaid managed care, in the realm of commercial claims, privately negotiated rebate arrangements between manufacturers and payers, in which the manufacturer agrees to pay rebates to get better formulary placement, under which they say, we don't want to pay rebates on already discounted 340B drugs. We have two sides of the coin, the manufacturer and covered entity, that really aren't responsible, right? It's not their fault. We're not pointing fingers in this presentation. What we're doing is presenting a value-based, market-forward, safety net fortifying solution to fortify public health in this country. That's really what we're doing, right? So I just wanted to be clear that, we're not pointing fingers here, but we have $15 billion apparently on the table, right? And we have a solution. Everyone should be working together for this solution, and we're going to get into it over the next, a few slides, why this is beneficial for the parties involved. Bill?
Yeah, I mean, I guess you could say that manufacturers and payers have created this double payment problem by entering into these rebate arrangements in the first place. And if they just didn't enter into such arrangements, that would solve the duplicate discount problem. But I think that is a naive approach. The reality is that there are longstanding benefits to the rebate arrangements that manufacturers and payers enter into that ultimately benefit patients and the sponsors of commercial plans. And just to say, oh, they should stop doing it is really not, it's not really a solution. I think it's better to accept that this is the way that manufacturers and payers work together, and that we should all try to address this duplicate discount problem together in a way that doesn't disadvantage any party.
And just to add on to that, just so for those on the call, I like to be a little anecdotal. Since my time working with Bill, he's been talking about a clearinghouse. So this isn't new. As a little tyke in the 340B program, I'm a bit appalled that it's taken this long, but I am thankful that RxParadigm has stepped up to the plate to do it. There might be others, but this is the only one I'm aware of right now. And I'll turn it back over to Carlo.
Yeah, thank you, Mark. Yeah, and the last point on this slide is that we like to share is that covered entities benefit zero from duplicate discount, right? But have really been absorbing all of the contract pharmacy restrictions. So really, the idea with pointing a solution to get all parties to the table to relieve the pressure is really where we're headed. I mentioned earlier, we think a lot of the root of the problem, or much of the root of the problem, is the claim modifiers, 340B claim modifiers. Again, it goes back to the old, I never took any computer science classes, but I've heard a million times garbage in, garbage out. And I'm not saying that the data is garbage, but it's just ineffective, right? I think if we look at this IQVIA report here, you can see from the payer channels on the graph and the columns, and the values in the columns are so some are high and some are low, that across all the payer channels and across the covered entities, that the use of the modifier is inconsistent at best. And this is really where the identification of the claims really starts. It's supposed to be at the point of sale. A lot of times it's not. And then after we review this slide, typically we point people to the information in the middle on the right, where if you looked at entity-owned pharmacies where control and volume is probably high, that the modifier is there 50% of the time on brand-eligible claims, 340B eligible claims, 50% of the time in a smaller environment. When you expand that out to the contract pharmacy environment, it's less than 1%.
Right. If I can jump in, Carlo?
Yeah, please.
Yeah, so and now of course this is IQVIA, and of course we could debate over, the data. But at the end of the day, I'm a pharmacist, right? As a pharmacist, it's difficult to enter claims. In a fast-paced pharmacy environment where you're just moving, for my pharmacists on the call, how busy we get. So we're going to get into it later, but we just wanted to, just let you know, like, we know that covered entities are compliant with their obligations under Medicaid fee-for-service. We know that. We know that otherwise you'd be seeing a ton of diversion findings every day. But it's difficult to enter claims, right? And they do it. They want to work with the state under Medicaid managed care to remove 340B drug utilization from rebate invoices. But, it's long, it's a long time coming to have a neutral party that doesn't share data where it doesn't need to go, that gets the job done for all the parties involved, including the federal government. So I just wanted to for my pharmacists on the line, we recognize the difficulties. And so this program will help alleviate those difficulties, and hopefully we can get some broad scale adoption of it for furtherance of the program.
Yeah, and point of sale identification is especially hard for covered entities and nearly impossible for contract pharmacies. So just because the identification of an eligible claim, a 340B eligible claim, takes time. And so you don't know at the time that the drug is being billed whether it's 340B eligible or not. So essentially, to get the identifier on there at the point of sale, you'd have to re-adjudicate all of those claims, which no one wants to do, either the payer nor the pharmacy wants to do. So this idea that you can identify claims retroactively is huge.
Yeah, and if I could add on to what Bill's saying, like, all right, so let's just level set here, right? We're lawyers, but you can't rely on what we're saying as legal advice. We are disclaiming any statements made here. It can't be relied on for the truth of the matter asserted. Don't use them in court. You can't. We're preventing you, and etc. Now, the covered entity does know who is its patients, right? Because the covered entity establishes and maintains an ongoing patient relationship. The pharmacists, they're not, they can. There's metrics. They're capable. But it's difficult, right? You're busy, right? And we would want the pharmacist to be freed up to do important things like drug disease state interaction checks and all these other patient pharmaceutical care services that are important throughout the country. So having the ability to identify claims, retrospectively, even though there are metrics and the patients are identified in advance, is fundamentally important for providing quality pharmaceutical services. Is this our slide, Carlos? Should we?
Oh, yeah, before we hop over to it, Mark, I'll just reiterate and just tell a quick story. We're working on a project right now in one of the states where much of the contract pharmacy volume goes through some of the larger chains. And the larger chains, to Mark's point and Bill's point, are extremely busy at their counters, and they have no time for this. So we're working in one of the states right now on a project where part of that driver, part of the need for the clearinghouse is because some of the larger pharmacies will not put the claim on, put the identifier in the claim at point of sale. They just won't do it. So they're actually relying on us to do it. So it is very real that is where and we know that's where the problem exists. So yeah, Mark, I'll throw it over to you to talk a little bit more about the benefits for all the stakeholders.
Yeah, so let's get into it, right? Like, why do this, right? We've talked about how this is critical, how this is a historic moment, but let's talk about the direct benefits to each of the parties. So for the drug makers, it's beneficial because they're not going to be paying those darn rebates on drugs that, according to their arrangements with the payers, they should not be paying rebates. Companies are identifying 340B drugs or choosing not to use 340B drugs under Medicaid fee-for-service. States are removing Medicaid 340B drugs from Medicaid managed care rebate invoices to manufacturers, but commercial claims, it's a big problem, right? So that's one big benefit to drug makers is they won't be paying those darn rebates on 340B already discounted products. And all the companies I've talked to, which is a lot, none of them have a problem with preventing those rebates from being paid, right? Because they're focused on providing safety net services. So what are the benefits for the covered entity? Just to be clear, we're going to get into some of these details, but the RxParadigm model does two main functions, right? It's removing 340B drug utilization from rebate invoices or subject that manufacturer would be paying. So that's the one function, but it's also serving as an important compliance tool, a backup check on it's capable of integrating with a medical record to do a back-end check on patient eligibility, which has extreme potential under the Inflation Reduction Act with negotiated prices, maximum fair price potential. Very important, futuristic, forward-thinking solution. And it's also providing just an added check with respect to patient eligibility. As we know, the 340 statute, diversion prohibition places discretion with the covered entity to determine who is its patients. That makes sense because the covered entity is the one establishing and maintaining that important patient relationship with underserved community individuals. But importantly, RxParadigm, works with the covered entity to implement the covered entity's patient eligibility determination and performs a backup check to determine if it's 340B drugs. Before you move on, if you could just go back.
Oh, sorry.
And then also there's benefits to plans, right? Like, for example, state Medicaid managed care claim 340B drugs should be removed from those rebate invoices. So the state Medicaid agency is responsible for that under the Affordable Care Act and under applicable regulations thereunder. And so, RxParadigm provides that added benefit to states. We're going to see the same thing under the IRA with respect to Medicare Part D and B drugs, because RxParadigm has it capable of neutrally clearing claims under both the medical and the retail benefits. And so there's a benefit for everybody. I don't want to be too kumbaya on this, but I really do think that the neutral solution is the way to go to get everybody where they want to be. We can move to the next slide. Bill, did you want to say anything before we jump into it?
Well, I mean, to address, I guess, another covered entity issue, which I think has been an impediment to the clearinghouse model, and that is the concern about discriminatory reimbursement. I think a number of covered entities are concerned that if they share claims data and manufacturers and payers are able to resolve the duplicate discount problem between them, in most cases, that results in the payer not getting the rebate from the manufacturer. And payers rely on those rebates to pay for their operations and to subsidize premiums and the like. So payers then are incentivized to make up the difference from the lost rebates. And what we have seen in the past is what we call discriminatory reimbursement or pickpocketing, that essentially there's a cut in reimbursement in the 340B market, either on 340B claims or to covered entities and their contract pharmacies in general. And so we recognize that that is a concern and a potential risk. However, more than half the states now have laws that prohibit discriminatory reimbursement. And we're making progress in Congress too on the PROTECT Act, which also would set a national standard that would protect against discriminatory reimbursement. So I think the fact that those protections are in place and are growing provides a platform then for a clearinghouse to step in and offer these services to the benefit of all the stakeholders.
Yeah, and to that point, I mean, we've seen federal legislation with PROTECT Act bills and the SUSTAIN Act bill with respect to 340B that propose a clearinghouse. But just keep in mind that for all the stakeholders, having the opportunity to do a program neutrally, the way, that benefits you and, can accept comments and integrate those comments and design a product for everyone, may be a better approach than a mandated program with which you have no input. So just wanted to throw that out there. So we're going to jump right into the benefits of the clearinghouse. So, these are generalized benefits, but I think that they are apparent, right? So there's a potential increase in safety net provider drug access, safety net access generally, right? It reduces the threat of drug maker restrictions. Parties disagree over that, whether they're illegal or not illegal. I have my viewpoint. But at the end of the day, if the parties are working together, especially with that carrot that's hanging out there with respect to commercial claims data, right? Covered entity's not getting any benefit, but the covered entity's commercial claims data is very important and valuable for the covered entity. An arrangement where there's an opportunity for value-based enterprise, value-based arrangements with respect to commercial claims data is truly an innovative, forward-thinking solution to eliminate billions of dollars in duplicate payments on the commercial side. So that we believe would incentivize reduced manufacturer restrictions, reduced restrictions on distribution of 340B drugs to contract pharmacy delivery locations, reduce the threat of the rebate model that we've seen. I mean, it's public knowledge. Johnson & Johnson proposed one. We know Caldero's proposed one. I personally believe that they're illegal, but there's no need for those things if we have a neutral process where all the stakeholders have input and all the stakeholders can feel safe with respect to the claims data. We're going to get into that with Tim explaining the fact that claims data is not being used. It's not given to any party that's not supposed to. It's a need to know basis, right? That's the reason for this neutral kind of intermediary to process the claims. It's really important. And it may reduce any other attempts to reduce the safety net program, right? I mean, the country relies on the public health care system, right? And we just saw the hurricanes that are coming through the Southeast and moving up. We saw the COVID pandemic, and we saw how important safety net providers were to meeting the needs of communities at those times. So we take threats to the public health system very seriously, national threats. And I do believe that the clearinghouse might be a workable solution for all parties, for them to benefit. So safety net provider access is one important point. The next one is potential to increase patient access, which is even more important to me as a pharmacist, right? Access to discounted drugs at contract pharmacies. We know under Section 330 of the Public Health Service Act, covered entity federally qualified health centers they provide pharmaceutical services and a lot of times on a sliding fee. But if they don't have access to 340B discounted drugs at the contract pharmacy, or if they're subject to a higher payment up front under certain rebate models, there's a potential they may be unable to provide those discounted drugs. We know hospitals provide discounted services and drugs through charity assistance program with respect to community needs assessments and to satisfy their contracts with local governments for providing indigent services, right? But if we don't have access at the pharmacies, we can't provide those services. The clearinghouse disincentivizes the restrictions that are harming underserved communities, while at the same time, they're benefiting manufacturers by identifying those rebates that they should not be paying. It benefits both parties, all parties. Safety net and public health services increase, right? So also with increased access to 340B drugs, wherever the company decides that they're, wherever their patients are located, according to the 340B statute, that increases the funding, the revenue that companies may be able to reinvest, which, I see on a firsthand basis with some of my largest hospitals that provide, $900 million in undercompensated, uncompensated services, including food, housing, to my smaller clients. I have smaller clients that have built grocery stores for their clients, that have shelters for their clients. So, increasing through a clearinghouse collaboration to generate funding to provide these critical safety net services is an important notable benefit to the clearinghouse model. Reducing the threat of a state mandated carve out, right? States are saying, oh, well, we're not going to, if you can't identify, we're going to just let's just carve it out, right? Don't use 340B for Medicaid managed care claims. And we know companies rely on reimbursement for Medicaid managed care because they serve a disproportionate share of underserved individuals who may be beneficiaries, members of Medicaid managed care plans. And so when you have a clearinghouse that actually assists the state with removing 340B utilization data from manufacturer rebate requests, then, it decreases the likelihood that a state may attempt a carve out like we saw in California and New York. And then also, and that would benefit patients because the company would then be able to use those resources to reinvest. And then also improving pharmacy efficiency, right? Like I said earlier, if I'm not spending time, in this fast-paced environment dispensing medications, I can focus on counseling patients and identifying those drug disease state, drug allergy interactions. Bill, anything on patient access and covered entity safety net provider access?
Yeah. So I don't, we can't say that by solving the duplicate discount problem through a neutral clearinghouse that manufacturers are no longer going to impose restrictions on contract pharmacy arrangements, or no longer going to pursue the rebate model, or engage in other strategies that limit the number of their drugs that are purchased through the 340B program. But I guess what we are saying is that it will be a lot harder for manufacturers, I think, to take those steps, because right now their primary defense for pursuing these restrictions is that it's to improve program integrity, that they're being subjected to all these duplicate discount problems, that they have to take matters into their own hands and establish these restrictions, especially relating to contract pharmacies. Well, if we solve that duplicate discount problem, we don't have that integrity defense anymore. And so how are they going to justify these restrictions? At that point, it looks a lot more like they simply don't want to have to sell so many drugs through the 340B program. And that, I think, is a lot less sympathetic for policymakers. And so I would like to think a lot of the drug companies would no longer pursue the restrictions. I just don't want to give the impression that they'll drop them, but I just think it would be harder for them to defend them if we solve this duplicate discount problem.
And Bill and I talk deeply about these things because we care so much about this program and the public health infrastructure of the country. But I will say that I do think that from my discussions with drug makers, commercial claims data, that realm of duplicate discounts is important to them. And so I do believe that there is a potential, as Bill noted, we can't guarantee anything, but I think there's a strong potential to incentivize collaboration between all the parties to reduce restrictions on access to discounted drugs and harming underserved communities. You can hit the next slide. Carlo, next slide.
Yeah, sorry about that. My computer would not catch up.
Great. There we go. Oh, did we skip a slide?
Did we? I'm sorry about that. My computer's playing catch up.
Oh, maybe not. All right, next slide. Let's keep that energy going. All right, so I mean, we've covered a lot of these topics. Why nutrient, why is this clearinghouse neutral, important right now? We've talked about the Protect Act, we've talked about the Sustain Act, but we've also talked about the Inflation Reduction Act. So right now, I think it's an inimitable time. That's why I think it's historic. I think I'm right about this. I tend to be right about these things. For broad scale adoption of a 340B neutral clearinghouse. And we're going to get into IRA issues. I believe it's still in the slide. And I'm going to explain the IRA duplicate. Well, maybe it's not in the slide. So I'll just very quickly explain the IRA duplicate discount issue, right? So under the IRA, manufacturers must provide access to a negotiated price, very discounted price. Right now, 10 Part D drugs, right? And what happens is Part D, Medicare, is going to be reimbursing pharmacies at that price, MFP, maximum fair price, at the point of sale. But the pharmacy might have purchased that drug in any price, right? Or the company might have purchased the drug at a different price. And so what CMS has said in its manufacturer guidelines is that manufacturers must pay within 14 days of a dispense wholesale acquisition cost, which is a very, it's pretty high, it's one of the higher prices, minus the maximum fair price Medicare negotiated price when they've identified a Part D beneficiary that has been dispensed one of those 10 drugs. So that's WAC minus MFP. But if the pharmacy acquired the drug at a different price, or if it's a 340B drug that's slightly more expensive or more expensive than MFP, the manufacturer really shouldn't have paid WAC minus MFP. The manufacturer should have paid 340B minus MFP. And if 340B is below MFP, manufacturer shouldn't have paid anything. Because the manufacturer is only supposed to be making the pharmacy whole for the difference between MFP, the negotiated Medicare price, and whatever the pharmacy's acquisition price is. So identify 340B drugs for that purpose is important. And I've talked to 340B stakeholders, and they see that as important too. By the way, none of that changes the text of the 340B statute, which requires that manufacturers offer and companies not be permissibly required to pay above a statutory ceiling price in the first instance. But what RxParadigm can do is, one, because it integrates with the EMR, it can flag those claims that might be 340B drugs within that 14-day period if the party so chose to use their platform that way. So that's a big deal. Also, because it does a retrospective kind of identification model, it can work with manufacturers with respect to those MFP rebates that are owed to pharmacies. We just think that this is a workable solution that won't necessitate the Johnson & Johnson or Calderos rebate models, and the parties can come together and work amicably together for the betterment of this country. So it's been a long time coming. It's going to reduce downstream costs associated with 340B ADR because everyone has buy-in. Everyone understands that RxParadigm's playing a role in double checking, reduces litigation related to, stemming from ADR disputes, stemming from manufacturer restrictions, stemming from any of this stuff that's related or stems from 340B claims identification issues, reduces the need for government audits, et cetera. So we just wanted to show that. And then also, I want to be clear, right? This is a neutral call. In addition to benefiting safety net providers, there's also the benefit that if drug makers aren't paying these crazy rebates, especially for commercial claims, they have the opportunity to perform more innovative research and design, which benefits everyone as well. So it truly is a neutral kind of construct. And because of, the IRA's implementation, because of the kind of, heightened environment with respect to 340B, I do believe that it's a good time for this. I think it should have been done back in 2010, 2013, with the Affordable Care Act, extended rebates to Medicaid managed care. But, finally, somebody has proposed something that is neutral. Bill?
Well, yeah, and as you said, the clearinghouse has been something that's been in discussion for a long time, and I remember sitting down and talking to manufacturers and payers about the idea of creating a clearinghouse, but it was focused exclusively on Medicaid. And I think covered entities have long thought that that's really the only area where they have to worry about duplicate discounts, because the law does indeed protect manufacturers from duplicate discounts in the Medicaid area. Um, but I have to say, my thinking has evolved. I think that of most covered entities have evolved a lot since then, because even though covered entities are not parties to these rebate arrangements between payers and manufacturers, it does impact them when duplicate discounts arise. It's often what is driving the restrictions that manufacturers are adopting. It's driving manufacturers' interest in reforming the 340B program, going to Congress and promoting changes to the program. So I think it's now clear that it's within the covered entity's interest to help solve the duplicate discounts on non-Medicaid claims.
Right.
Because even though there may not be a direct link to covered entities, there's certainly an indirect link. And so it would take the pressure off of the reform efforts, take the pressure off of the restrictions that are just creating such problems for the covered entity community.
Yeah. And so I'll move through these last two really quickly, Carlo, if you want to just click the next one.
Yeah, for
I
sure.
want to turn it over to Tim. Yep. So we've talked about, a non-neutral rebate model and the threats of that decreases the opportunity to provide sliding fee discounts. Some say it's the fox guarding the hen house. We think something that's neutral benefits everyone. Next slide. Oh, you're moving the content.
Sorry.
All right, cool. Bill's already talked about the fact that clearinghouse is already included in federal bills, and we think that showing that it works through a neutral model will benefit all parties. And we also think that there's benefits to this clearinghouse mechanism of double checking with respect to audits, right? It could help companies prove that this is their patient and that they followed the metrics, and just another data point, another evidentiary point. It also helps manufacturers. They could possibly use it with respect to some of their reporting requirements and inflationary penalties and things of that nature. Next slide, please. So now I'm going to turn it over to Tim to talk about, if we have time, some of the metrics and operations on how this thing works.
Yeah, thank you, Mark. Yeah, I think I can take about 6 minutes. We have about 10 minutes for Q&A. So let me get going here. Appreciate it. So yeah, so operationalizing this, how do we make it go, right? Hit the go button. We're already working with a number of CEs and state PCA groups. And for those CEs that we're either actively working with or starting to work with, there's a number of very common questions that they ask. We imagine that these are probably similar questions that might be rallied around in your brain as well before you say, yes, I want to engage, and yes, I want to hit the go button on the clearinghouse. First question is about security. How secure is the clearinghouse? And Carlo alluded to it, but by end of the year, we will be HITRUST certified. For those that aren't familiar with HITRUST, it is the gold standard in healthcare tech IT security. It demonstrates that we have top of the line data privacy, data security, and IT best practice in general. So the clearinghouse will be HITRUST certified in that respect. On top of that, we do recognize that you're not going to take our word for it. So we're very happy to have your IT teams look at our private policies, look at our procedures and processes around data security and privacy, so we can also prove that to you. So security is a big question we get a lot about the clearinghouse with our current partners. Second question we get most commonly is around impact to their day-to-day processes. So would the CE's day-to-day processes around 340B program compliance, identification, replenishment change drastically? And the answer is absolutely not. So the clearinghouse is working so that you operate as you normally would with your 340B program. All we're asking is that the same data elements that you're either giving to your 340B TPAs or getting from them are also shared with the clearinghouse, so we can validate and certify a claim as 340B to facilitate this collaboration with manufacturers. Third most common questions around external audits. So as every CE knows, at least once a year, you've got to have an external audit of your program to make sure that you're compliant to 340B. So what is different about an external audit versus what we're doing? And our answer to that is that external audits are around compliance with an individual CE program, but that data is not available to drug manufacturers. And on top of that, the data that's looked at as part of an audit is usually a very small sample size. So what the manufacturers are asking for and needing is a neutral, independent third party to validate the claims so that they feel confident that if they use that information to identify these duplicate discounts for commercial Medicare and Medicaid, that it's accurate and also complete. Fourth most common question is around resources. Everyone is strapped, right? Budget, resources, especially IT resources. As we said before, and I'll show you in the next slide, the data requirements that we're asking for are very similar to what you give a TPA and what you get from a TPA, 340B TPA. So the uplifts should be very minimal. Last questions around the data sharing. So what options do we offer, right? Can we automate this or help you automate this process? And the answer is yes. So we're very flexible. We offer automated SFTP, secure SFTP. We have secure APIs for those that are more mature on the IT spectrum. And we also offer good old-fashioned, user interfaces to manually upload the files as well. We do offer custom solutions. So if there's some need you can't meet that you need a custom solution for, we're also very happy to do that as well. So those are some of the things that the CEs that we're currently working with asked us, and we're able to overcome to actually make it happen for them. Next slide, please. So at a high level, we could take a whole hour just going through the details of how this clearinghouse would work. But at a high level, if you look at the very bottom of the slide, what we're asking CEs to give, as I mentioned before, are the similar data that you're giving to your TPAs or getting from your TPAs today. So nothing more, nothing less. That data is then shared with the clearinghouse in the middle there. So Tungsten Plus is our brand, but it's actually the clearinghouse. And as I think Mark mentioned, we're not sharing that detailed claim data with any other stakeholder. So take manufacturer at the very top there. So they'll be loading their rebate claims that they get from payers, the rebate invoices. And all the clearinghouse is doing a match of the 340B claims from the CE to the manufacturer rebate claim. And if there is a match, it annotates that rebate claim with a yes or no, right? Is it 340B or not 340B? No other data on that claim is shared with the manufacturer or with any other stakeholder on this slide, state and MCO programs or payers if they participate as well. So again, data security and data privacy is very important to us, and we're only sharing what is absolutely needed to help the manufacturer and other stakeholders mitigate the duplicate discount problem. Next slide, Carlo. So how can you hit the go button? How can you get engaged? I think we'll hit the Q&A. You have a lot of good questions already, but you'll be happy to know that the clearinghouse is already a go. So we already have a number of CEs engaged and working with us. We have a couple of state PCAs also engaged with us, MCOs. So the clearinghouse is already happening. So it's already in place. But this is a trigger point for us to launch it to the broader covered entity and manufacturer audience. There'll be more to come on this. But for you to get engaged, we recommend 3 things. Number 1 is reach out, be proactive, right? We'll probably reach out to you shortly, but reach out to us to start the conversation. So Carlo Cioffi from RxParadigm on the call here. You can see his wonderful face there. Please reach out to him. He's happy and more than willing to talk to you about next steps on the clearinghouse with your manufacturer or a covered entity. If you're a covered entity, alternatively, if you'd like, you can work through your local state PCA or hospital association. It's a good chance we're already working with them or have engaged them, but that's also a valid place to start to go through your local PCA or hospital association chapters. On top of that, what we'd recommend is that you start to learn about our data sharing requirements. So we'll be publishing them over the coming weeks. proactively sharing them. So start understanding what those data sharing requirements look like against what you're already giving to your TPAs and getting back to get aligned. And then as part of that, when we get ready to implement with you, get your IT resources ready to go to kind of get those feeds over to the clearinghouse. When you're ready, hit the go button on the clearinghouse. So I'll stop talking. I know we want to leave some time. I'll pass back to you, Crow, to wrap us up and start the Q&A process.
Yeah, I think we can hop right into Q&A. I think Sophie's got her eye on the Q&A chat button, and I think they've seen a couple come in. So Sophie, do you want to read a couple of these? Start, top and work down, I guess.
Sure. There are questions in both the Q&A and the chat, so I'll start in the Q&A section and then move on to the chat. So first question, would this replace the Oregon Clearinghouse if we are in Oregon?
I don't think that this. Oh, go ahead, Tim.
I think that would be the long-term desire. So if the clearinghouse becomes a national solution, like we think it will, then I think Oregon would be very incentivized to work with our clearinghouse and to decommission theirs. But that's very early days, I would say. But Mark, please.
And before that occurs, I do think that it would work in conjunction with said clearinghouse. I think there's opportunities for it to work, the RxParadigm model or whichever, to work in conjunction with the Oregon, because remember now, Oregon only relates to Medicaid managed care.
I think that's the important point. Yeah, that's the important point here is that the Oregon model is limited to Medicaid, and the RxParadigm clearinghouse is all claims. So they could be, I guess, operate side by side, but I think it would be more efficient if over time, as Tim mentions, the RxParadigm model is adopted.
Yeah, and one thing I'll say, I know we have a ton of questions. Just remember now, the threat up against that we're, up against, it's covered entities at least, or even in manufacturers, because, terminating a pharmaceutical pricing agreement is very serious, and that was just proposed, historic moments. So we have a solution. I know there's some reluctance, and there's always reluctance. I represent safety net providers. I'm reluctant. I'm a litigant. I do it. But just keep in mind that collaboration gets the job done. All right, we can move to the next question.
If the clearinghouse is going to be expected, is the clearinghouse going to be expected to cover the cost? If the manufacturer is really the winner. Sorry, is the cover entity expected to cover the cost of the clearinghouse?
Yeah, I think there's 2 points here. One, just keep in mind it's a compliance tool. Cover entities are responsible for removing Medicaid fee-for-service claims, and just keep in mind under payer contracts, let's say Medicaid managed care PBM's contract, they have terms that require identification of 340B drugs so that the state can remove such drugs from the utilization data submitted to manufacturers. So that's an important, compliance is why we went into those benefits. That's an important compliance benefit for the CE community. I do think that, that's a business decision on the cost. From my review of this, I don't want to speak out of turn. It seemed like a nominal cost for the covered entity side. A, B, I think that with respect to commercial claims, I'll let you all talk to individually. I strongly suggest reaching out to RxParadigm. You can reach out to me too, about, economics related to commercial claims data, which I think are valuable to covered entities. There might be shared savings, value-based opportunities there. So I really do think, I don't want us to get caught up in the weeds over, some, for many minor costs, minor monthly costs compared to the massive compliance and economic benefits that we're talking about here. But I don't want to oversell it as well. I mean, look, I represent safety net providers that are cash strapped. And so any fee is a fee. But I do think that there's opportunities, and I do think RxParadigm is willing to discuss. All the parties are getting some benefit out of it. It's not just covering, manufacturers, rebates. There's benefits from a compliance perspective and possible value-based arrangements with respect to commercial claims. Tim?
No, you nailed it, Mark. I think our point of view is that both sides need some skin in the game, right? If we only took money from manufacturers, then we would risk our neutrality at that point, right? So there has to be some skin in the game for CEs. So there will be a nominal fee. The CEs that we're working with today either can cover the cost themselves, it's very small. In many cases, their local PCA or hospital association picks up the tab. There's nothing unreasonable, I would say, but it's an important approach that we don't take money just from manufacturers as part of this. Otherwise, we're the same risk that other players have, which is playing
Tim.
one side versus the other.
Tim, just the point is that the Sustain Act requires the covered entities to pay for the clearinghouse proposed there under, and it requires commercial, it mentions commercial claims data, and we know there's no federal statute that requires a commercial entity to give up its commercial valuable private claims data. So I guess the point that I'm trying to make to the covered entity community is that this is a real opportunity, and I'm always trying to protect you. You know that about me. And so I wouldn't feel, and it's voluntary, like no one's mandating you do it at this point, right? So you can really talk and negotiate, but all the parties have to have skin in the game in order for it to be neutral, as Tim said.
Yeah, thanks, Mark.
Thanks, Mark. And just to put a finer point on that, in one of the state meetings that Tim and I were invited to, since 2020, the health centers have lost over $150 million in shared savings. And again, our stance is that none of this is going to change unless activity is taken, right? Action has to be taken for us to really start to move the ball down the line. So we hear what everyone's saying on the cost piece, and as Tim said, we've built it accordingly so that we're just not not non-neutral, I guess is the best way to say it. So Sophie, next question, please.
With the complexity of managing the 340B program, what incentive do we have to correct something that's not our responsibility? Manufacturers aren't playing nice when it comes to the 340B program. In fact, their attacks on the 340B program do greatly affect covered entities. It might be naive to think that manufacturers will stop entering into these voluntary agreements with PBMs. However, double payments is not a covered entity issue. Only duplicate discounts that involve Medicaid are the responsibility of covered entities.
Yeah, that's a good point. Bill and I, like I said, I should sleep more because of what that comment says, right? I'm always working on that. And like you said, I don't represent drug makers. So you're preaching to the preacher and the choir, right? But I want to make one point clear, right? If you don't speak for yourself, somebody's going to speak for you. And I've said value-based enterprises probably like 5 times now. Someone mentioned shared savings arrangements. There's a massive value associated with the covered entity's commercial claims data. I personally do not want what could be arguably unconstitutional bill requiring a covered entity to give its commercial claims data up and pay to give it up. That's what's, and I support the Sustain Act big time. I support fortifying and protecting public health infrastructure, but I just really need, those who are questioning, and also I just want to do this. It's a compliance tool, right? Like it's another data point that you can use. It's another defense mechanism. I'm dealing with notices of disagreement with the federal government where, covered entities have to provide massive amounts of information to protect, their programs. And so what we have here is a neutral party that won't be giving information to others that don't need it. They're going to clear these claims. But it's solving the Medicaid managed care problem to which you arguably are responsible. Not responsible to repay, but if a payer contract, PBM contract, says identify 340B claims, now we have, that is a problem, right? And then you're going to be calling me to protect you when you have this neutral clearinghouse that can identify those claims for you, not to mention implementation of the Inflation Reduction Act, right? So I agree 100%. Coverage is only required to prevent Medicaid fee-for-service duplicate discounts, 1,000%. And I agree, the safety net needs contract pharmacies, the safety net needs access to 340B drugs, but just keep in mind this historic opportunity and solution that's being proposed today. I wouldn't be presenting if I didn't think that there was a need in the market for this solution. Bill?
Well, yeah, I mean, this comment is exactly my approach for many, many years. It's only recently that I've shifted my views, and that's because manufacturers and payers are being harmed because of this duplicate discount problem, and they in turn are trying to reform the program. They're imposing restrictions, all of which are not within the interests of the covered entity community, or harming covered entities. And so if we get to the root of the problem, which is solving this duplicate discount problem, it will take away the pressure for manufacturers and payers to engage in those problematic policies.
There's more questions. I do want to respect everyone's time. You have our email addresses here. Please feel free to reach out to Tim and Carlo. Bill and I are very busy people, but we're always available, especially the safety net providers. Carlo, Tim, you want to close it out?
Yeah, I think what we'll do, Carlo, is the questions we didn't answer, we'll, in our follow-up to all the people that attended, we will provide those answers and also post them up as well.
Yeah, that'd be great. That's what we'll do. So for sure. Well, thank you everybody for your time. Bill and Mark, thank you. And we appreciate you joining us today. And we hope to hear from everybody soon. Our contact information is on our website and here as well. So again, have a great day, everybody. Thank you.
Thank you.